Okay, class, today we will be covering hypovolemic shock and as well as the stages of shock. So when we're looking at shock, we're going to talk about the various stages of shock, and the way that we're going to do that is we're going to use hypovolemic shock as our exemplar. So remember that shock is an inadequate means of tissue perfusion. Now there's three things that really impact how perfusion takes place, and that is the amount of blood volume, your cardiac output, and then the size and integrity of your vascular bed. Now knowing that if your patient has a decrease in the amount of blood, we know that that will also cause a decrease in the amount of cardiac output. Cardiac output will then also decrease in cardiac output will also cause the decrease in the MAP, and you'll also have a decrease in tissue perfusion. Also, if the vascular bed dilates, you know that there's a decrease in the mean arterial pressure, decrease in the blood pressure. If the vascular bed constricts, then we'll see an increase in MAP and also an increase in blood pressure. So just think about those things as we progress on. As we move forward, if we can catch patients that are developing shock and we can do something about it, catch it within the first 1 to 2 hours, it's reversible. However, if we don't catch it, if we don't recognize the signs and symptoms, then these patients may progress to worsening tissue damage, organ damage, multiple organ system damage, and also death. So here we're going to discuss a little bit about the various stages of shock. There's 4 stages. We have the initial stage, the compensatory stage, progressive stage, and the refractory stage. So let's dig into those just a little bit more. In the very beginning stage, in the initial stage, what we often see is there's just a slight decrease in our mean arterial pressure. The body can compensate for this. So the first thing that you're going to see in the initial stage is you're going to notice that the patient's heart rate goes up. And you also may notice a slight increase in the respiration. Along at that same time, you might see a slight change in the diastolic blood pressure. It'll slightly go up, but everything may still be normal. So if a patient comes in and their heart rate's in the 80s, respirations are 14, blood pressure's 120 over 80, and then when we go back later and repeat that, and so now your heart rate's gone up just a little, it's increased, and now it's in the 90s, and the respirations are 18, and diastolic blood pressure was, 120 over 80, so now it's 120 over 83, 84. Those things have all changed, but they're all normal. So often when we don't follow up on changes in the patient's vital signs or changes in the patient's condition, we miss it at this stage. Lots of places implement a Muse score, which is a modified early warning system, and your book talks about that. It's so important because when you have changes in these areas, it alerts you that there's a change, and it makes the nurses, they're responsible to go back in and evaluate their patient. If the techs are taking their blood pressures, techs aren't going to tell you, they don't notice if there's a change. That's your responsibility. So make sure that you're paying attention. Patients aren't really going to have any symptoms because that compensating is maintaining the cardiac output in their MAP. Tissue perfusion is actually being maintained at this stage, but the body's not performing optimally. And there is a slight increase in anaerobic metabolism going on at this time, and it's causing the lactic acid to, a byproduct of anaerobic metabolism is lactic acid. So understand that while we don't necessarily notice anything, not having an abnormal lab at this particular time, lactic acid is starting to increase slightly, and that will lead to more problems if we let this continue to progress. Hard to catch, so pay really close attention to what your patient's got going on. As we move into the compensatory stage, this is the next stage. At this particular time, just the increase in heart rate, the increase in respiration rate, the slight increase in that diastolic pressure aren't keeping up. And the body recognizes this. When the body recognizes this, the you can't keep up with your mean arterial pressure, so that means that your organs and your tissues not getting perfused. And so what happens is you see that the body starts releasing renin, ADH, aldosterone, epinephrine, and norepinephrine. So we know that epinephrine and norepinephrine cause vasoconstriction. Well, if we have vasoconstriction, that means that our vascular bed becomes vasoconstricted, right? So that's going to help your MAP go up. You also are going to see that the renin and aldosterone ADH levels, they're going to have your body try to hold on as much fluid as possible in order to try to increase cardiac output and increase the amount of circulating blood volume. At this point, too, though, what you're going to see is decreased urine output, because if your body's trying to hold on to excess fluid, then they're not going to be urinating as much. When that takes place, you're going to have a greater absorption of sodium. You're going to have increased constriction of those blood vessels. When you do have that constriction to the blood vessels, you got to think, though, what's going to constrict first? The blood vessels going to the skin, the GI tract, and other unvital organs or less vital organs are going to be the first thing that you actually see. The body's going to try to protect and maintain those most essential vital organs first before it is like the skin and the GI tract. So as vasoconstriction goes on, how would you know that the patient might have vasoconstriction? You can't look and say, oh, the veins are smaller now. Let's go get the vein finder. I don't think that's what we're going to do. But the skin's going to be cool. You can listen to those bowel sounds now, and maybe you're having hypoactive bowel sounds, or most likely you will. Also checking the pulse. So you may notice that the patient's pulse is no longer a normal 2+, and maybe it's just weak, and it's becoming like harder to feel. Decreased blood pressure from baseline. As that lactic acid, more and more cells and more tissue are now having to do anaerobic metabolism. When that takes place, you have more and more lactic acid building up. So what do we have? The MAP decreases by 10 to 15. Moderate vasoconstriction, decreased urinary output, changes to our blood pressure, acidosis. This is also the time where you start noticing hyperkalemia. You know, hyperkalemia, we've talked about that already, can lead to the cardiac dysrhythmias. Oxygen saturations are going to start to fall at this time. The first sign that you're going to notice as far as the central nervous system sign is the patient's going to have increased thirst. When that takes place, when your lady keeps saying, hey, will you bring me some water? And you're like, really? I just brought you water. You know, pay attention to that. That could be a sign that the patient's entering into shock. They become restless, kind of anxious, breathing fast, heart rate's fast. So just make sure that those things, the little things, you got to catch on to these little things as they progress through the stages. If you stop it, if you do catch it at this particular stage, at the compensatory stage, everything can be reversed and there will be no permanent damage. If you do not recognize the signs and symptoms, though, the patient can continue to progress and they may not be able to fully recover. So write these things down. What do we need to know about the compensatory stage? What do you expect to find for each of these? And I'm going to allow you guys to go and complete this chart. So remember, do what I ask. Okay, so we didn't catch it, so now our patient has progressed and we're into the progressive stage. During the progressive stage, the vital organs are becoming hypoxic. The non-vital organs at this stage are becoming ischemic and the tissue is starting to die. You know, earlier we mentioned the skin was cool, now it's becoming cold and clammy. We got to stop this within an hour or the patient's going to progress. This is a life-threatening emergency. What are you going to see? This is when your MAP actually decreases by 20 millimeters of mercury from the baseline. Your compensation is no longer keeping up, causing your pH to continue to drop. Your lactic acid continues to go up, yielding the low pH. And then that potassium level continues to go up as well. Vital organs cannot function very long at this stage, so we must, again, catch this. So what are some things that you may see in this? Your patient really feels like, oh my God, something's bad. I'm about to die. Something bad's happening. They continue to have an increase in a worsening thirst. At this stage, we said that the pulse was getting weaker. At this, it's getting rapid, a little thready pulse at this time. You may also notice that the patients are becoming having pallor and cyanosis in this stage. They're going to be cool or cold to moist. And at this stage, they may have no urine output. Also, at this stage, you're going to see a much larger drop in your O2 sat from 5 to 20%. As far as their mental status change, they're going to be confused at this time. And I already mentioned, oh my God, something bad is about to happen, that impending doom. It's also at this time that you start seeing the capillaries start to leak. And when capillaries start to leak, remember they start allowing protein to seep into the interstitial spaces. When that protein starts leaking in the interstitial spaces, then that means more fluid is going to the interstitial spaces. And that's when you're going to start seeing systemic edema throughout the whole body, and that anascara, where you have just profuse, profound edema everywhere. Also in the progressive stage, we got a dramatic decrease in cardiac output. We have decrease in the tissue perfusion with severe hypotension. At this point, you may not be able to feel the pulses, or they're really weak and thready. You can see that they have ischemia to the distal extremities. Also, this stage, you may see that the the heart starts to dysfunction, and with the elevated potassium, you may see dysrhythmias. You can see that the patients start exhibiting heart attacks, and overall, what happens is the cardiovascular system fails. And we know once the cardiovascular system fails and the cardiac output plummets even more and more, that the patient's chance of survival really does plummet. Also at this stage, I mentioned about the fluid leaking into the interstitial spaces. Is also in this stage when we start have patients progress to ARDS. Now we know with ARDS, fluid starts getting into those alveoli sac, and they start being able to have a ventilation perfusion mismatch where they're breathing in the air, but because of the fluid, they can't pick up the oxygen. And they also have worsening tachypnea and crackles. These patients, they quit making an adequate amount of surfactant, so you gotta, at this point, then patients will need to be ventilated. Patients will quickly progress into the refractory stage. During the refractory stage, vital organs now have extensive damage. The liver, the heart, the brain, and the kidneys, they're going to be lost. When that starts taking place, when more than one organ becomes damaged, you actually have multiple organ dysfunction syndrome. And we know once the liver is damaged, then we're not making clotting factors, and patients are going to then be at risk for like bleeding everywhere, like DIC. You're going to have no urine output. The patients are going to become, they're going to go from the confused state that we talked about earlier into the loss of level of consciousness until they're going to be non-responsive at this stage. So what will your signs of refractory and multiple organ dysfunction syndrome look like? Again, that's the loss of consciousness. You're not going to be able to feel the pulses at this stage. You're going to have to get a Doppler and hope that you can even find them. Respirations are going to slow down severely, and you're not going to even be able to measure your O2 sat because perfusion will be so low. So this is just a little picture or drawing of the signs of the various stages of shock. Some of you guys like those. I actually like them. We'll probably see if I could draw those on my own. So as we begin, one of the things that we got to do and promote health promotion with maintenance with the patient is compare heart rates and pulse quality with the baseline. So knowing what your pulses were graded at. We did that back in fundamentals, and you guys were like, I can't tell if it's a 2 or a 3. The main thing is you know what it was when you started, what it was when the patient came in, and has it changed. Compare your urine output with fluids intake. If they're taking in 3,000 units of or liters of fluid and they're only got 100 urine output, you're gonna need to be concerned. You start having all of a sudden weight gain, or if they start having a change in their vital signs, Don't forget that persistent thirst is a big deal. Pain, because as tissues start dying, they're going to have increased like skeletal pain and that type of thing. Worsening anxiety, first they're kind of anxious, restless, and then they become irritable, and then they can become like, oh my God, like just panicky, and then they actually lose their level of consciousness. So just think about how they may progress in the stages of shock. One of the key things that you have to do also is you have to be prepared to notice who is at risk for shock. So I just put some pictures up to give you some things to think about. Who's going to be at risk for shock, going into shock? Of course, elderly are always increased risk. Anybody that's got a liver problem is going to be at risk. Anybody that's getting IV fluids, especially if those IV fluids are contaminated, will be at risk. People that are bleeding, people that have injuries, wounds, stab wounds, leg amputated, maybe accidents, people that are vomiting, nausea, diarrhea, that kind of thing will also. And then people, different drugs cause you to lose fluid volume, or people that overdose on drugs may also cause overload.